Hi friends, we are going to continue the infective endocarditis video part 2. Friends, as we discussed earlier, yesterday night I have sent the blood culture and we'll see what will be the report in that blood culture, which organism will come. But that by that we can see, is there a need for 2D echo? We can assess. By this table we'll know Staph aureus. If the blood culture isolate has shown Staph aureus, we'll see. We'll rule out what the patient we have. In Staph aureus, blood culture came and the patient has an intracardiac device, prior endocarditis history, IV drug user, cerebral or peripheral emboli, meningitis, pre-existing valve disease, persistent bacteremia like more than 72 hours, vertebral osteomyelitis, community acquisition, non-nosocomial, healthcare association, indeterminate or positive transthoracic echocardiogram. Okay, I think that, and as my ma'am has said, the patient may have vertebral osteomyelitis. But let's see if this is the case. If the blood culture isolate is Staph aureus, if the blood culture isolate comes as enterofacialis, then symptoms should be more than or equal to 7 days. Emboli, greater than 2 positive cultures of E. coli and E. fecalis, no focus or no origin, heart murmur, valve disease, including prior endocarditis. When I heard this heart murmur, as I said earlier, my patient has a pansystolic murmur. We'll see. And non-beta hemolytic streptococci. Symptoms should be more than 7 days, greater than 2 positive cultures. These two are common for both. And one species, like Streptococcus gallolyticus or Streptococcus sanguinis S mutans, heart murmur or valve disease cannot be acquired. As I said, my SR ma'am said before there was a case of transesophageal echo. That case was a positive Streptococcus sanguinis systems. Okay. Now there are three. If these three blood culture isolates Staph aureus, Enterococcus fecalis, non-beta hemolytic streptococci like Streptococcus sanguinis or gallolyticus or mutants. Okay. Next, we have suspected in the patient we have suspected infective endocarditis. See if the patient has a high risk of suspicion or is a low risk of suspicion. Let's first see high risk, high initial patient risk, because my patient is a high initial patient risk. I have high clinical suspicion, so I should ideally start with a transesophageal echo. As my center is not that advanced in that investigations, we have referred the patient for a transthoracic echo. Let's see. As we have high clinical suspicion, what should we generally do? We should do generally a transesophageal echo. If the transesophageal echo is positive, we can give direct treatment. And we'll follow up with transesophageal echo or transthoracic echo for vegetations, complications, and treatment response. If the initial transesophageal echo is negative in a high risk, high clinical suspicion patient, we'll see still the clinical suspicion persists or not. If it persists, repeat transesophageal echo. If not, look for other source of symptoms or alternate diagnosis. If on repeat transesophageal echo is it positive, then go for treatment. If it is negative, consider other tests like CTA or FDG PET, or go with your clinical judgment. And if the initial infective endocarditis suspicion was low, then we'll do a transthoracic echo as we are doing in this patient today, my patient. We'll see if the echo is positive, we'll start the treatment. And if there are any high risk echo features, then we'll go for transesophageal echo. If there are no high risk features, no need, unless the patient deteriorates. And initial echo was negative, then we'll see still low clinical suspicion is there. We'll look for any other source. If there is increased suspicion, no problem, go for a transesophageal echo. And if it's positive, go for the treatment. And here friends, now I'll give a brief antibiotic treatment of the infective endocarditis caused by the common organisms that we generally see in our daily practice. Streptococci. There are various types of streptococci which are penicillin susceptible, relatively penicillin resistant, moderately penicillin resistant. In penicillin susceptible streptococci, like Streptococcus gallolecticus, we can give penicillin 2 to 3 millionunits for 4 weeks, or can use ampicillin or amoxicillin if penicillin is naive. Penicillin 2 to 3, ceftriaxone 2 grams. This was the question I asked today, and I stumbled and I told 1 gram. It's 2 grams. Okay, single dose for 4 weeks. Okay, and vancomycin 15 milligrams per kg. The patient when it is 55 kgs. So you can calculate 15 into 55. How much the dose should I give for this vancomycin? ये भी 4 weeks के लिए. अगर कुछ penicillin allergy है तो भी remember one common thing is if the patient is penicillin allergic, you should ask the history and check the testing dose. If he has penicillin allergy, then you can go with vancomycin or penicillin G or ceftriaxone 2 grams for 2 weeks. Plus you can add gentamicin 3 mg per kg IV or IM for 2 weeks. You can divide the 4 weeks. Instead of a mono drug, you can give 2 drugs, uh, penicillin or ceftriaxone added with gentamicin. Relatively penicillin resistant, Streptococcus gallolecticus or MIC titer, we should check. Then penicillin G 4 millions or ceftriaxone 2 for 4 weeks. Plus, you will give gentamicin as said earlier 3 mg per kg for 2 weeks. Or you can give vancomycin for 6 weeks, as I said, if he is allergic to penicillin. And moderately penicillin resistant. Now it's moderately penicillin resistant streptococci. Then what we will do? Penicillin G 4 to 5 millionits or ceftriaxone 2 grams for 6 weeks. As you are noting, first the treatment was single drug for 4 weeks, or added drugs or 2 drugs for 2 weeks. And as resistance increases, we are giving increased dose for 4 weeks or vancomycin for 6 weeks. And if there is moderately penicillin resistant, then we are giving treatment for 6 weeks. Okay, remember it. Penicillin ऐसे दे सकते हैं, penicillin or ceftriaxone for 6 weeks, added with gentamicin 3 mg per kg for 6 weeks, or individually vancomycin for 6 weeks. Okay, now streptococci has been done. We will see with enterococci. Enterococci, penicillin G, as said earlier, plus gentamicin for 4 to 6 weeks, or ampicillin instead of penicillin plus gentamicin for 4 to 6 weeks, or vancomycin plus gentamicin both for 6 weeks, or ampicillin plus ceftriaxone, the starting regimen, both for 6 weeks. This last is used if it is Enterococcus faecalis, because Enterococcus faecalis is resistant for vancomycin. Remember this point. Why we are giving ampicillin plus ceftriaxone, leaving vancomycin out of the picture? Because Enterococcus faecalis isolate has high resistance to gentamicin and vancomycin also. Staph aureus. Now coming to the most common organism, Staph aureus. If Staph aureus MSSA, like methicillin sensitive, then we can give lifacillin, oxacillin for 6 weeks, or cefazolin 2 grams for 6 weeks, or vancomycin for 6 weeks. As I said, vancomycin we will use in penicillin resistant patient, penicillin allergic patients. And MRSA affecting native valves will give vancomycin for 6 weeks or daptomycin for 6 weeks. If OE-MRSA, if it is infecting prosthetic valves, will give vancomycin for 6 to 8 weeks added with gentamicin 1 mg per kg for 2 weeks plus rifampin for 6 to 8 weeks. You understood? If the same MRSA it is acting on if it is infecting native valves, then we have simple treatment vancomycin or daptomycin for 6 weeks. If the same MRSA is affecting in prosthetic valves, then we have vancomycin for 6 to 8 weeks plus gentamicin for 2 weeks plus rifampin for 6 to 8 weeks. If the same methicillin sensitive is affecting native valves, we have said earlier nafcillin, nafcillin or oxacillin or cefazolin or vancomycin for 6 weeks. Now, if the same thing is infecting prosthetic valves, the common thing is added with that gentamicin plus rifampin. If gentamicin for 2 weeks rifampin for 6 to 8 weeks. So what did you understand? If there is a picture of prosthetic valves in the patient which are getting infected, we should add two extra things. One, gentamicin, 1 gram, 1 milligram per kg body weight for 2 weeks, and rifampin for 6 to 8 weeks. Okay. And finally, Haeckel group of organisms which are little rare to see, ceftriaxone 2 grams for 4 weeks, or you can give ampicillin or sulbactam for 4 weeks. Coxiella bruneti, as we know in the criteria, single positive culture for Coxiella bruneti is a major criteria. Coxiella bruneti can be treated easily, doxycycline 100 mg plus hydroxychloroquine, both for at least 18 to 24 months, like more than 1 year. 18 months in native valve, prosthetic valve में तो treatment का time बढ़ता है 24 hour. And Bartonella species also doxycycline for 6 weeks or gentamicin for 2 weeks. If doxy is not tolerated, you can use azithro 500 mg. Anything for 6 weeks. Okay, finally, indications of cardiac surgical treatment in patients with endocarditis when the surgery is required for optimal outcome. We'll see in next video.